Sara Rependa, and this is my colleague Kristina Cordeiro, and we're both graduate students at York University in Dr. Robert Muller's Trauma and Attachment Lab. And today Kristina and I are going to be presenting on trauma practice, which is a triphasic trauma treatment model that has been developed by Drs. Anna Baranowski and Eric Gentry. So, the triphase model trauma practice is a development of Judith Herman's concept of phasic treatment for trauma from her book Trauma and Recovery. The model is structured so that each phase incorporates what Drs. Baranowski and Gentry identify as sort of the four key ingredients for competent trauma treatment. And these ingredients are therapeutic alliance, relaxation or self-regulation, exposure such as a trauma narrative, and cognitive restructuring. And the trauma practice model is also rooted in a combination of cognitive theory, behavioral theory, psychophysiology, and neuroplasticity. Like many effective trauma treatment models, trauma practice is stepwise and made up of three phases. And these are safety and stabilization, the work with the actual trauma material or working through trauma, and then phase 3 is reconnection. So we start with phase 1, safety and stabilization. Trauma practice attempts to define and operationalize the concept of stabilization by proposing 3 different levels of achieving safety for trauma survivors. The first level is resolution of impending environmental and physical danger, so removing them from the actual physical danger. The second is the amelioration of self-destructive thoughts, suicidal behaviors, ideation, addiction, risk-taking behaviors, etc. And then the third level is restructuring of victim identity into survivor identity by providing self-care skills such as relaxation skills, containment, grounding, that sort of thing. Theoretically, after these steps are achieved, the clinician can then transition the client into phase 2, which is working with the client. So the interesting question that comes from that is, how do I know my client is ready to move into phase 2 work? And the great thing about trauma practice, and one of the interesting things about this model, is that it attempts to answer this question. In practice, it's a difficult question to answer, and past treatment models as well as past literature have not yet achieved in answering this question. So we try to directly address this. The model proposes several possible transition criteria to help the clinician with their decision as to whether the client is ready to move forward or not. So the first criteria includes resolution of impending environmental danger, ensuring the client is out of any active danger, removed from harmful environment. Secondly, they outline the importance of the client being able to distinguish between am safe and feel safe. Taken further, this means the ability to know the difference between physical outside danger, or quote-unquote real danger, and then inside danger, which includes fear of intrusive post-traumatic symptoms such as anxiety, flashbacks, and nightmares. The third proposed criteria in the trauma practice model is that the client has developed a toolbox of self-soothing, grounding, containment, and regulatory skills to deal with their inside dangers. The practice manual gives us a whole bunch of different tools in a variety of different ways, and the client should be able to demonstrate use of these tools before moving into phase 2 work. The last criteria that they propose is that steps should be taken place to have a transparent conversation with the client before moving into phase 2. This includes openly discussing with their client mutual goals for phase 2 work, openly celebrating the successful achievement and accomplishment of phase 1 work so that they have this sense of accomplishment, and then discussing openly what they'll be doing in phase 2, which is working directly with traumatic material. These criteria are merely guidelines, of course, and it's emphasized that the clinician should always use judgment above all else when deciding to advance. However, we found that this criteria is a great way of sort of operationalizing the idea of whether or not to move forward with clients into phase 2 work. So now that we're actually in phase 2 and we're working with traumatic material, we know that the goal of this phase is to lessen distress, desensitize the client to trauma memories, restructure problematic belief systems that may surround the trauma. Like many trauma treatment models, this is done with a mixture of different exposure techniques, such as trauma narratives. And throughout the phase, the clinician is essentially exposing the client in various different ways to their personal traumatic material, while using the self-regulation, containment, and grounding tools that were taught in phase 1. And this helps the client process, it helps them to integrate the memories into their own narrative, their own physiological narrative, and then become desensitized to it. In the 3rd edition of the Trauma Practice Manual, a new and interesting exposure technique was added, and it's different from or unique from other exposure exercises in that the material that the client is being exposed to is not the actual traumatic memories themselves, but in fact the broader belief systems or core beliefs that the client may be struggling with or having difficulty shaking. So these can include things such as nobody loves me, it's my fault, I'm a bad person. As clinicians, we sometimes see that we're unable to get to the root of the distress, even after working with various traumatic memories on numerous occasions with numerous different exposure tools. And these core belief systems that the client carries may extend beyond just the simple traumatic event and can be difficult to shift, therefore creating problems even after the exposure has been done with the traumatic material. The thematic map and release exercise addresses these core fundamental beliefs more directly and comprehensively. So in the Trauma Practice Manual, the exercise is outlined step by step. She gives a really great script. I won't go through every step, but I'll sort of take you through the general process. So first, we will have already identified a core belief that the client has in the previous session. So that could be something like, it's my fault, or I am bad, or I am dirty, something like that. And then we'll begin the session by asking the client to think about this core problematic theme or belief. We then describe to the client that when we talk about something or are trying to access a memory, we often look up or down or to the side. This exercise, in fact, deliberately tries to access different types of information by having the client focus on various predetermined focus points, such as up and to the left, down and to the right, right into the center, so that the client then thinks about this belief and allows whatever thoughts there are to surface without suppression or judgment. The client holds their gaze on these focus points for 30 to 60 seconds while thinking about the pre-identified belief. And then the client allows whatever emotions, thoughts, bodily sensations to surface, letting the therapist know what they are becoming aware of. They then complete what is called a guided release exercise. So the release exercises uses imagery that is taught to the client and the therapist guides the client through it as a way of relaxing them and releasing the tension that the client may have or any negative feelings that might have been brought up by thinking about the core belief. So we ask the client to picture being filled with warm, smooth grains of sand and then allowing the sand to spill out of them slowly, grain by grain. And we ask the client to picture negative emotions and beliefs and anxieties to attach to each grain of sand as the sand slowly spills out of them grain by grain. The relaxation exercise is completed with every focus point, and there are 7 different focus points: up and to the left, up and to the right, down and to the left, down and to the right, center left, and then center. The exercise takes about 50 minutes, so it's important to know that you're going to do the exercise before you start it and have an idea that you're going to be doing it with the client. It's also recommended that you allow time at the end of the session to complete perhaps a grounding or relaxation exercise after the thematic map to reinforce the safety and stabilization, because you will be dealing with such difficult thoughts and underlying beliefs. So that then brings us to phase 3, which is reconnection, and it involves consolidation of the self-efficacy that the client has learned throughout therapy. It's used to promote acceptance, closure, reflection of the difficult process the client has gone through. Clients are encouraged to create new goals for themselves as they begin to become free from the emotional restrictions that the trauma has caused. And there's also several exercises to help them memorialize and say goodbye to the different memories and thoughts and ways of thinking they have to move forward. Phase 3 also allows the client to reflect positively on what they've completed and to celebrate the accomplishment of the work that they've put into throughout the therapy. Chris? So that's a little bit about the actual trauma practice model, and now Chris is going to talk about the research.
So yes, now that Sarah's done a wonderful job describing for you what the trauma practice model looks like, I'm going to take you through the current research study underway and also discuss with you our very first research participant in the study, JT. So in collaboration with Dr. Baranowski, we are conducting the very first study to systematically evaluate the effectiveness of trauma practice. And the importance of using evidence-based approaches is something that I'm sure we're all quite familiar with. But I want to make an important distinction between effectiveness and efficacy studies, where efficacy studies really look at how treatments work in ideal situations that are very controlled. But effectiveness studies look at how those treatments work in the real world, so with clinicians out doing their practice, already working with this approach. So what we're interested in looking at is how effective the trauma practice model is with therapists who are already using the approach. Right now we have 6 therapists that are recruiting participants from their practice, primarily private practice. And these are experienced therapists who have worked with clients who have histories of trauma and who are also familiar with the trauma practice model. Each month they meet with Dr. Baranowski and Sara and myself for clinical supervision, partially to make sure that there is adherence to the model, but also to support them as they start collecting data for us on the project. In terms of eligibility criteria, we have indicated that it should be a type 1 trauma, so the reason or presenting concern is a type 1 trauma, but as we all know, history of trauma is a major risk factor for future traumatization. So a lot of these individuals, even though they're coming in presenting because of a single isolated event, they often have a history of complex trauma, and that's okay, we understand that, and they are welcome to be a part of the study. Additionally, we ask that it's the first time they're seeking treatment for that particular experience or traumatic event, and they should not have any other serious psychological difficulties that might interrupt the therapeutic process. Because we're interested in both outcomes and treatment progress, we're collecting data at a couple of time points, pre and post-treatment, and then every time the client is transitioning from one treatment phase to another, they're also asked to complete some questionnaire. So if they're moving from safety and stabilization into working with the trauma, we ask them to complete some measures at that time point. What we're hoping to do is that by collecting this data throughout therapy, we can highlight the unique effectiveness of each phase of treatment, which might actually be really informative and help us understand how to help those who have limited resources, who don't have the luxury of long-term treatment. And then in terms of questionnaires or measures that we're interested in, we are looking at PTSD symptom and symptom severity, emotion regulation, self-esteem, therapeutic alliance, and post-traumatic growth as well. So now that you have an idea of what we're doing with the study, I'm going to spend a little bit of time talking with you about our very first research participant, JT, who is working with Dr. Baranowski, pictured here. Now, JT has really provided us with a unique opportunity not only to understand the effectiveness of the trauma practice model, but he's given us permission to videotape some sessions with him for training purposes, and has also consented to have us show you some of his thematic mapping experiences here today. Just as a background, JT is a 47-year-old man who was working as a veterinary technician for the last 25 years. He's always loved animals, and especially dogs. In fact, he's been so successful in his job, everyone around him knows him as JT the dog guy. He's kind of like a real-life dog whisperer. And I'll get to his type 1 or index trauma in a moment, but I just wanted to take a moment to highlight that it is complicated. So like many of the clients who come to therapy because of a similar type 1 trauma, JT has quite a complex history. He was raised in quite a disadvantaged neighborhood, exposed to a lot of violence and drug use. his father committed suicide when he was still a teenager, and he described his mom as emotionally unavailable. He was sexually assaulted by someone quite close to him and developed a substance use disorder in his early 20s. When we interviewed him, he said that it was his love for dogs and his work with them that kind of helped him heal and move on from that darker time in his life. And has really helped him kind of move past everything. So the current index trauma was a vicious dog attack that happened while at work that left him with 40 puncture wounds all over his body, and he had to be hospitalized for over a week, actually. He was forced to go back to work after 8 days by WSIB, and he has ongoing issues with WSIB right now. Interestingly, for JT, the most traumatic aspect of the attack wasn't the attack itself, but it was a breach of trust that he had experienced with his manager and long-term friend at work. He had actually communicated with this individual his concerns about that particular dog in advance, saying that he felt the dog was unpredictable, very aggressive, and that he wasn't comfortable working with the dog, and yet nothing was done to change that. And it was 3 days after he had sent an official email that he was attacked by that dog. Listed here are some of the many symptoms that JD endorsed when completing our questionnaires. We see many of the ones that we are familiar with, so flashbacks, isolation, restless sleep, and nightmares. When we interviewed him, he actually expressed that for him the most distressing symptom was this loss of identity. Having been known as JT the dog guy, he finds himself now unable to even walk in a dog park without having a full-blown panic attack. He doesn't really know what his role at work is going to be like anymore. He can't walk on the street without being afraid he's going to run into a dog. So he's sort of left thinking, well, who am I, and where do I go from here? Currently, JT is working through phase 2 of the trauma practice model, so he's still, the data we're collecting is still ongoing with him. One interesting thing that came out with our interview with him, and I thought it would be nice to talk about today, is the recognition that while some of the techniques that are available to therapists through the trauma practice model are familiar to us and maybe not, they don't seem strange to us, to a client that might not necessarily be the case. He had said that he was quite skeptical and hesitant with some of the techniques, and he had called thematic mapping the QQI stuff when we had interviewed with him. But then he went on to say that he was really surprised at how effective it was at helping him regulate his experience, both in session and outside of session as well. And he had said, I can say with 100% confidence that without the work we've been doing together, I'd still be where I was when I started. In many ways, I have risen above. So here we have an example of Dr. Baranowski doing the thematic mapping and release exercise that Sara spoke about earlier.
So what I'm going to do is, because we already have the theme, we can start by focusing on the theme itself, and I'm going to have you just reflect on no one believes me, when you were in danger, and they were more interested in their own comfort and safety than in you and your well-being. It's hard to trust being in this place, right?
Yes.
That's the belief.
Yes.
And you just told me that it's still ignitable to around a 6 or a 7, which is significant, right?
Yes.
So what we want to do is have you focus up on the tip of the pen with your eyes only, and I want you to hold that focus point. And as you do, I want you to allow the thoughts of that theme. No one believes me when I was in danger. They were more interested in their own comfort and safety than me, and it makes it hard to trust in this place, right? So I want you to let whatever thoughts, emotions, and body sensations surface as you hold that focus point on that theme, and then close your eyes. And as you close your eyes, I want you to allow whatever thoughts, emotions, and body sensations surface in whatever way they do. And as they do, I want you to allow yourself to help me to understand, Jane, what thoughts, emotions, and body sensations go along with that.
So then JT takes a few minutes to describe how he's feeling and thinking and experiencing that theme in that moment, after which they begin the release portion of the exercise, which Sara described earlier, and we'll see that next.
We probably should. I think he's telling us to stop.
Yeah, okay, thank you. So in terms of, then just quickly, in terms of JT's progress through treatment, again, it's still quite early. We only have 2 time points from him, but he's reported quite significant improvements in his emotion regulation, specifically fewer outbursts at work and having less avoidance of his work as well. And our take-home messages are really that the trauma practice model is a useful toolbox for clinicians, that it draws on behavioral, cognitive, and psychophysiological approaches. It is a triphasic model, as Sara had described, and that it works with complex trauma too. So even though we're not including that in our treatment, it is anecdotally, we know, quite effective with complex trauma. And that even though clients may express some hesitation, as therapists, it's our job to call in our therapeutic alliance with that client, normalize the experience for them, and maybe explain to them why these techniques are quite important and effective. Thank you.
So if you're interested in some of this material, if you can visit these websites, then it is available to see some of these videos, because the client he's very excited about sharing his experience, and it is available for you to see. So, thank you.